Popular meeting we've had so far. So within the first 24 hours of putting out the call, we had 25 acceptances, and it's now at 70. It's obviously the drawing power of the speaker this evening. So it's fantastic to introduce Michelle, and she's the Director of Neuromuscular Services at Sydney Children's Hospital and Senior Lecturer of Neurology at the University of New South Wales. So I first encountered Michelle when Annie Bai knocked on my door and said, I've got the most brilliant neurologist of the generation who needs to have some neurophysiology exposure. And Annie wasn't wrong. She's been a real driven force and did her PhD looking at spinal muscular atrophy and has now gone on to develop various clinical cohorts through neuromuscular services at Sydney Children's Hospital. And she's going to give us an approach to spinal muscular atrophy, particularly for the adult neurologists. So thanks, Michelle.
Thanks, Matthew, for asking me to talk tonight. So what I hope to cover tonight is to introduce spinal muscular atrophy to you all, and do that really through some clinical cases that I've encountered in adults, and cover a diagnostic approach, and also discuss what I'm currently passionate about, which is emerging therapies in spinal muscular atrophy. So spinal muscular atrophy is defined as a hereditable group of disorders. It's characterised by loss of the motor neurons in the spinal cord, which you see at the top of the picture. And on muscle biopsy, that's manifested with denervation, and you can see groups of small fibres that are denervated, but there's also reinnervation, so that you see groups of large fibres that have also been reinnervated. It's a very broad condition, many different phenotypes, and they're differentiated by the pattern of muscle weakness, and really is it predominantly proximal muscle weakness or is it distal muscle weakness? The other way that I approach them is by the age of onset and also the inheritance pattern, which can be recessive, dominant or X-linked. And so far, because they are hereditary, there's 33 genes described so far. Might have changed, I don't know. It's rapidly advancing. So what I really want to do is provide an adult perspective. So the first case would be one of the more common that you would encounter, and that's Kugelberg-Wieslander disease, or proximal SMA. And this is one of the patients that was part of my cohort, a 26-year-old female who graduated from the Children's Hospital after presenting at the age of 12 years. And she came to the clinic saying, I just can't get up from the dance floor. She was learning dancing, and that's what she was passionate about. And on closer questioning, really she had trouble getting up and down the stairs. She needed to hold the handrail, and she was a really clumsy runner and not very good at sports, and that had always been the case. She had a tremor in her hands, which was long-standing, and the really interesting thing, which a lot of my patients tell me, is that there really wasn't a clear progression for quite a long period of time. If she looked over the last 5 years, she could no longer get up from the floor with assistance, but that's really over 14 years since diagnosis, so it's pretty static for her, but maybe some slow decline. She was very physically active at the age of 26. She was a hairdresser. She stood up all day. She said she felt tired at the end of the day when she was blow-drying hair. But every morning she got up and she did 20 minutes on the treadmill. She walked 3 kilometres, and she also did biceps curls and was able to curl 1 kilo, which is probably better than what I can do. So she'd also had a pregnancy and carried the baby without too much of a problem and not had a significant exacerbation. So in terms of her diagnostic approach, which was in 1995, she had a lot of the typical features. She had proximal muscle weakness. Her legs were more affected than her arms. So really it's the SMA with Kugelberg-Wieslander and the more severe types, it's the quadriceps. It seems to be segmental, and they're the most affected. And really, then the triceps, C7, seems to be more affected out of the segments in the cervical spinal cord, and certainly her clinical examination was consistent with that. She had a normal sensory exam because sensory is not affected. She had normal bulbar function absent deep tendon reflexes. In 1995, her workup consisted of neurophysiology, and what you would see is that the sensory nerve conduction studies are completely normal, and she had a modest reduction of her compound muscle action potentials, but her distal latency and motor conduction velocities were preserved. And really, you have to have a significant loss, a significant reduction in Cmaps to get any prolongation of latencies or motor conduction velocities. Her EMG was neurogenic, and her CK was normal, but certainly I think it's a flag that in Kugelberg-Wieslander disease, you can present with a raised CK up to 3,000. So if you have someone with proximal weakness, calf hypertrophy and a raised CK, don't just go down the muscle pathway, use the neurophysiology to guide you. Now, in 1995, she had a muscle biopsy, which showed the denervation that I showed you in the first slide. And it was in 1996 that the gene was discovered. And she subsequently went on and had the testing for survival motor neuron 1 gene and confirmed her diagnosis of 5q SMA or Kugelberg-Wieslander disease. So this is a diagnostic algorithm which was published in The Lancet, which I go back to frequently when I see patients in clinic, and it's very useful. So it's quite simple. If you've got someone with proximal weakness and neurogenic EMG and you do the gene test and you confirm a homozygous deletion, you know, that process doesn't take long and you can get the diagnosis, but not all of my patients are that straightforward. And the lesson I've learnt along the way is know the test you're ordering, know the pitfalls, the sensitivity, so that you can take it further and potentially get the right diagnosis. So it's an autosomal recessive condition. So if you really are convinced that it's neurogenic and it's predominantly proximal muscle weakness, and the genetic test does not confirm it, the next step is to do the SMN1 gene count. So what can happen is that 5% of cases of Kugelberg-Wieslander and the other types of SMA can have a deletion on one and a point mutation on the other allele, and the first test does not pick that up. So if you do a gene count and you find one copy of SMN1, it could still be SMN1 SMA and compound heterozygous disease, deletion and point mutation. So if I get a report and I think it's SMA and I'm surprised when there's no homozygous deletion, I ring the lab. How many copies were there? If there's one, I take it further. I get them to sequence the gene. And then they might find the point mutation and you've got your diagnosis. But I have been tricked once. There was one patient I was absolutely convinced, and they had one copy of SMN1. We sequenced the gene and nothing was found. I'm like, well, I still think that's the most likely diagnosis clinically. And we took it further. We got lymphoblasts and we asked the lab to do protein expression. And that patient, they didn't express the protein. So we didn't find the mutation, but that was another way that we could confirm SMA in that patient. Now, that's a very rare situation, but it really shows that if you're clinically convinced, if you know the test, you can really work it out. I think if you've got two copies of SMN1, you've got to think of your differential diagnoses. It's unlikely to be SMN1 disease, and really in infancy you'd consider SMARD, but in adults maybe X-linked SMA, which is Kennedy's disease, and that presents typically with proximal and distal weakness fasciculations, but also the bulbar phenotype and the endocrine issues as well. And in terms of the differential diagnosis beyond that, it's really going back to the clinical and using the neurophysiology to help you work out the differential. So if you had a diffuse pattern of weakness and a normal EMG, normal CK, it's probably not peripheral. Go on and think about central problems, spinal cord problems, go down that avenue. Whereas if you've the neurophysiology may also reveal that it's a demyelinating neuropathy, an axonal neuropathy. Look for neuromuscular junction disorders and also for myopathy, and based on what you find on neurophysiology, that would guide your further investigations, muscle biopsies for myopathy, genetic testings for muscular dystrophies or myasthenic syndromes. So Kugelberg-Wieslander, looking at the history of it, it was actually described by two groups within 12 months of each other in 1955, the first being Wolfhart, Fex and Eliasson, and they described 3 families, and interestingly they said it simulates progressive muscular dystrophy. But if you look at their abstract, which it's hard to read, but they said it's probably a benign variant of Wernicke-Hoffmann disease, but it may actually be a completely different disease, we're not sure. But really the features were that it looked like a limb girdle muscular dystrophy, and you can really see that in the picture, the pronounced wasting of the quadriceps. And they show the muscle biopsy, which is neurogenic, so it's not a muscular dystrophy. And similarly, the report that was published within 12 months by Kugelberg and Wielander was 12 patients, and they said it looks like a muscular dystrophy, but again, the EMG and muscle biopsy are neurogenic, and they said, is this a type of a benign variant of Wernicke-Hoffmann disease? And it was really debated for the next 40 years. Are they the same disease? Are they different? Are they distinct? So as you can see, what they're debating is it the same as Wernicke-Hoffmann disease, where the babies present and it's a devastating diagnosis where they usually die by the age of 2 years, or is it an intermediate type? And in fact, it was actually Wernicke-Hoffmann that described the intermediate type, and it's now misnamed as SMA type 1, which can happen in neurology. And it was the discovery of the gene in 1995, 20 years ago now, that really answered the questions and said, yes, it is the same disease, and it's due to a loss of the survival motor neuron 1 gene on chromosome 5. And it was really trying to understand the genetics that really helped understand why the spectrum is so broad. So chromosome 5 is an area where there's been an inverse duplication in chimpanzees and humans only. And so what's happened is that as it flipped over on itself and it copied itself, you got a second almost identical copy of the SMN1 gene, and that's called SMN2. Now, it only varies by 11 nucleotides, and none of them change the amino acid sequence. So, but some of the changes change the splicing. So what happens is that you can produce a small amount of the protein, survival motor neuron 1 protein. So that's why it's not embryonically lethal. You don't see this disease in mice or other animals because they don't have the duplication. But it's not enough to rescue the phenotype, but it's enough so that you can be born. And the copy number of SMN2 varies between individuals. Some people have 1 copy, some people have 8, and that is why it's so different. The people with 1 copy have very bad disease, and people with 8 copies don't even get SMA. So thinking about SMA and it being classed within motor neuron diseases, it's very bizarre to me. It's thought to be a neurodegenerative disease, but when I think motor neuron disease, neurodegeneration, I think of ALS. Insidious onset, relentless, rapidly progressive loss all along the way. Whereas SMA doesn't really do that. So I find that quite curious, and I was trying to understand this. So one of the studies I did was look at the natural history of the survival of the Sydney Children's Hospital cohort from the time of genetic testing, and we'd looked after 70 patients. And when you look at survival, what it shows is that type 1, which is the most severe or infantile form, the majority do not survive beyond the age of 2 years. Whereas if you look at the type 2 form, which is the intermediate form, and type 3, which is Kugelberg-Wielander, really there may be an early loss there, but as the disease goes on, it gets more stable, and it doesn't look like what you'd expect for a neurodegenerative disease, and it really raises questions about what's going on, what's the pathophysiological process. And one of the theories, I think, which this really does sort of support, is that there's an upfront course, so that there's a very early loss of motor neurons, and then it reaches a plateau phase where there's stability. And I think what that is depicting is that the age of onset or manifestation really depends on how many motor neurons are lost early and what the demands are on them. So that you have increasing muscle mass from the time you're born, and you have increasing requirements for motor development through life. So that if you lose a profound number early on, it's going to manifest very early. Whereas if you've lost only less and it's more intermediate, you're not actually going to present at such a young age. It's only going to be when the motor neurons are not sufficient to keep up with the muscle mass and the demands for their innovation. And I think really when I see the patients that present, they're not really presenting with a loss of function. A lot of them are presenting because they're not meeting their expectations. So a young baby may be presenting because it's not sitting when it's expected to be, or a young child may be presenting because it's not pulling to stand when it's expected to be, or walking at the typical age. And I think the case of even the 12-year-old, it was that, you know, she wanted to do something but she couldn't, so she wasn't really reaching what her expectations were. She didn't say she'd lost function, she just couldn't do the things that she wanted to do. And I think looking at that disease course, I think sure there might be some more degeneration later on in life, but that's very slow. It makes it very tricky when you're trying to look at treatments and measure the success of them. When a lot of the outcome measures for clinical trials are motor function scales, muscle strength, are they going to be sensitive enough to detect a change? And is that going to be what makes a clinical trial fail because the design is not sufficient enough to demonstrate an effect? And I think that's really an important issue. So one of the studies I did taking the previous cohort was to recruit a number of them into this study, which was a study on 25 people in the chronic phase of SMA. And I combined clinical assessments, functional assessments, genetic assessments of SMN2 copy number and neurophysiological assessments to really work out what was happening to them at that point in time. And what the neurophysiological assessments using nerve excitability techniques revealed was that there was a mixed pathology. And what that pathology was that there was a degenerative process, but at the same time there was a second process, and that was a compensatory process with re-innovation occurring at the same time. And I think that's probably what's underlying this plateau phase. It's not that nothing's happening. I think there's two processes balancing each other out, or trying to. And one of the interesting things was that discrete excitability measures were able to separate these two processes, which conventional CMAPs cannot do. And they also correlated with motor function, such that I think it may be, we're in the process of further looking at this, particularly longitudinally and in younger cohorts, to develop as a potential outcome measure in clinical trials that might be sensitive enough to really reveal what's happening pathophysiologically and the potential response to therapies. So moving past the most common form of SMA, which is SMN1 disease, there are a number of differential diagnoses, and it's probably about 2 to 4% of proximal SMA patients, so it's not common, but I think there's more genes to be discovered, because really if you look at the pattern of them, they don't describe all the patients I see. Most of them are dominant, and then there's Kennedy's, which is X-linked recessive, whereas I think I've seen some patients that have recessive SMA and we don't yet have the diagnosis. Interestingly, one of these congenital SMA with lower extremity dominance was described in Sydney by Kathy North and Steve Riddell, and it was a family that presented with predominantly lower extremity weakness and wasting early in life, but they also had upper extremity weakness, as you can see with the scoliosis. But one of the things that this study was really powerful in showing was that there was a death of one of the young children in the second year of life from meningitis, not related to SMA, and a post-mortem was done. And what you can see is the profound loss of the ventral nerve roots in comparison to the sensory nerve roots. And that clearly demonstrates the developmental hypothesis that early on there's a substantial and deep loss of motor neurons. So distal SMA is quite different to proximal SMA, and it's really defined by a progressive distal weakness of the motor nerves, sparing of the sensory again. And to date, there's been 19 genes described, and I'm sure that will be changing rapidly. And the original classification was based on that from Anita Harding over in the UK, and she described 7 types of hereditary motor neuropathy, which is synonymous with distal SMA. And the classification was again age of onset, pattern of inheritance and pattern of weakness. I actually initially found this quite confusing, but spending more time looking at this table, I can kind of work out that some of the patients, particularly if they present with HMN type 5 upper limb predominance, you can pick it out and that can really help you sort it out. But I think it's a real mixed bag, and you can see that some of the genes like GARS are over there, and they're also described in Charcot-Marie-Tooth disease. And what that really illustrates is it's quite heterogeneous. There's a lot of overlap. One gene could be distal SMA, it could be type 1, or it could be type 3, or it also could be Charcot-Marie-Tooth disease. And then I think after Anita Harding's classification, new phenotypes continue to be described. One of the interesting ones is scapuloperoneal SMA, which can mimic FSH, and that's linked to TRPV4, which codes for a cation channel. So I just wanted to present 2 cases that I've seen of distal SMA to describe an approach, and sometimes you get it fairly quickly and sometimes it's harder to work it out. The first was a 41-year-old male who presented with child onset hand weakness and toe walking. There was a slow progression, and by the time we saw him, he was working as a motor mechanic. He could no longer use the spanners and turn it, had no sensory symptoms, and you know, you sat down and you took a family history, and it pretty quickly became evident that it was autosomal dominant. So he went on to have, these are his photos, and you can see the marked wasting. I can't even pick an APB muscle in his hand, and there's also marked wasting of the interossei, and he had the pes cavus and the wasting of his lower limbs. So he went on and had neurophysiology first of all, and that confirmed a motor neuropathy. Normal sensory studies reduced CMAPs, normal motor conduction velocities, and the EMG was neurogenic. Because of looking at the Harding classification, he really did clearly fit the phenotype of HMN type 5, which is predominantly upper limb in its presentation, and that early on, and an autosomal dominant history. So looking that up, it really helped us know which gene to test first of all, which is BSCL2, which encodes for a protein called sapin, and that's also called Silver syndrome. So getting the right phenotype, taking the family history and doing nerve conduction studies really helped us get the answer fairly quickly. But it's not always that easy. So this is a patient who's 54, and he had onset in his 20s. Initially, he couldn't stand on his toes. It was slowly progressive, but he had widespread and prominent fasciculations, particularly over his back and over his shoulders. His weakness was more in his legs and his arms. It was more distal than proximal, but it certainly did involve his thighs, and it certainly did involve his triceps and his scapula. His reflexes were preserved in his upper limbs but absent in his lower limbs, and you can see the picture of his hand also shows wasting of the dorsal interossei. But really, I think the first symptom for him was the calf predominance of the symptoms. So he then went on really for a 30-year diagnostic odyssey. His nerve conduction studies showed a motor neuropathy, so I suppose we did confirm the diagnosis of distal SMA with him. His muscle biopsy showed chronic denervation, and he had proximal and distal weakness, so he had testing of SMN1. He also had testing of FSH, which is the great mimicker. It can present with a neurogenic pattern and a foot drop. And then looking at his phenotype, sure, he had hand weaknesses. He got the same condition as the previous patient. He had BSCL2. He also had the genes described for HMN type 1, which is the autosomal dominant lower limb distal weakness of HMN. They didn't show it. He also had TRBV4, because that's scapuloperoneal muscular atrophy, and we still didn't have a diagnosis. So where to from here? He kept coming back to clinic. He wanted to know the diagnosis. So really, it was around the time next generation sequencing was starting to be talked about. So the question was, which one do we do? Should we do a neuromuscular panel or should we do a whole exome sequence? So I've recently learned about the pros and cons of both. So at Sydney Children's Hospital, we've been sending some of our patients for neuromuscular panel to Perth. Now, it can sequence 400 of the known genes in neuromuscular diseases. Might take 6 months, and they'll charge the hospital genetics budget $1,200. But the thing I've learned is the phenotype is essential. So if you write on the form distal myopathy, they will sequence the genes known with distal myopathy. If you write on the form muscular dystrophy, that's what they'll look at. And it doesn't pick up duplication. So it's looking for changes in genes, but if you've got 2 copies or you're missing SMN1, it won't pick it up. So that's why I think this patient, you have to know the test, and it will miss certain conditions like FSH, myotonic dystrophy, triplet repeat disorders. So if you still have to think before you write the test, and you have to write the right phenotype on the form. At the moment, I emailed them, and if you write motor neuron disease, SMA, they will look at 50 genes associated with SMA and motor neuron disease. And the good thing is they only look at those genes, so if you find that you're a carrier or you're going to get BRCA1, you don't find that out, so you don't get incidental findings. But really my problem with this man was that you look at the known genes associated with distal SMA, he's had most of them. I don't think sending the panel, you're going to find it with him. So maybe whole exome sequencing, where you have the potential to discover new genes that aren't on the panel, is a better way to go. So it can sequence lots of genes at the same time, and it can discover new genes. And in fact, if you look at the literature, using whole exome sequencing in cohort 6 SMA genes have been discovered in the last 4 to 5 years. Again, it doesn't look for deletions or duplications, and there is the problem of finding incidental findings. At Prince of Wales, where exome sequencing is being undertaken, they'll charge $2,500 to sequence one patient. But if you find a new gene, you often have to segregate it within families and check that it is in fact disease causing. So if you do a trio, that will cost $4,400. Now, we were fortunate that we had a grant from motor neuron diseases to look at SMA genes and phenotypes. So we went on to do this in this patient and his affected brother, and we found a missense mutation in a gene called FBX038. And fortunately, Garth had also seen the deceased father and was able to help by providing the DNA on the father, which also confirmed that he had the same mutation. And a month before we got the results, it was published. And it was published in 2 families who presented exactly like this man. It was like I was reading his case history. Autosomal dominant distal spinal muscular atrophy with calf predominance. It began in the calves, it was slowly progressive, it was distal and proximal, it also involved the arms, particularly the triceps and the intrinsic hand muscles, and the age of onset was variable from 13 to 48 years, and the severity was also variable. So I think the take-home message for him was that the new technologies of next-generation sequencing can be very helpful and expedite diagnoses, but at the same time, you need to know the test and what you're ordering so you know what it can help you with and what it can't help you with. And I still think the clinical phenotype has to be spot on, otherwise you put junk in, you might get junk out. So I wanted to move on to emerging therapies, which is exciting. And it's really been 20 years since the gene was first discovered, and that's really been 20 years of efforts to understand the genetic underpinnings of SMN1, SMA, that's really developed a strategy to develop new therapies. So as I said, that one of the single nucleotides between SMN1 and SMN2 is a C to T change. It doesn't change the protein code, but what it does is it changes splicing so that in SMN2, the majority of protein transcripts do not include exon 7. and that's an unstable protein that's rapidly degraded. So a lot of the therapeutic strategies have been directed at changing splicing. Can you modulate it? Can you turn the promoter on SMN2 to make more gene, and some of it will be full length? Can you do gene therapy to reintroduce SMN1, or can you provide neuroprotective strategies? And really that has been a major focus of the NIH in the US for the last 20 years. And you can really see that because at the moment there's 17 compounds in therapeutic development, which is just phenomenal. There's 12 pharmaceutical companies investing in that. There's 6 in clinical trials in humans, and 2 of them are in phase 3 trials. So I think we're at the point where we're going to know fairly soon if some of these therapies are going to work. And I think that's really based on the real promising stuff from preclinical studies, animal models, cell models, trying to develop the strategy and take it forward. So the first one, which was the most advanced, is olazoxime, and that was really identified by looking at what growth factors prolonged motor neuron survival in cultures. And this compound was derived as a cocktail of 3 growth factors, and it looks like cholesterol, and in fact it was first tested in ALS but didn't show an effect. But it was also tested in SMA, and the study, the company Trophos released the results on their website last October. And what the results, they're not published, but if you look at the website and their press release, and they presented it at the American Academy of Neurology as well, was a randomised control trial of 165 non-ambulatory patients aged 3 to 25 years old. And what the compound was demonstrated to do, and it's neuroprotective in its effects, is that it preserved motor function for the 2 years they were on it using the motor function measure scale. And I didn't know what that scale was, so I went and looked it up. It's a scale that the maximum score is 96 on motor function. Now, is that meaningful? When they looked at the placebo, there was a mean loss of 1.9 points of motor function over the 2 years. So they went from 39% to 37%, whereas if you're on the treatment, you stayed the same. So the company is seeking regulatory approval, but I'm yet to be convinced as to how meaningful that will be. I think the patients will say it is, if it's stopping deterioration over a long period of time, but I can't really decipher how meaningful that is from what they say, but I think that's what the regulatory bodies will be asking. The study that we're involved with is an antisense oligonucleotide treatment. So what you can do is you can synthesise nucleic acids that bind to either DNA or mRNA. And originally they were designed to stop genes being expressed. So you bound the gene and you stopped it being translated and expressed. But what the antisense oligonucleotide in SMA is doing, it's binding to intron splice inhibitor segments. So if you bind to that, what will happen is that you will include exon 7 when you're splicing SMN2, so that you're going to change it so that more full-length protein is being expressed. Isis Pharmaceuticals have been developing this, and it's now in phase 3 clinical trials, and we're involved in the symptomatic SMA type 1 study, which is aiming to recruit 100 patients to demonstrate efficacy. And what the trial involves is 6 injections intrathecally of the antisense oligonucleotide. And it's really, I think the phase 2 studies have, which again were presented at the American Academy of Neurology, have revealed that the survival in type 1 is prolonged by 4 months. And in some of the subjects, there is improvement in motor function over that time, which I've never seen before. So some of the babies are getting better head control, some of the babies are rolling, some of the babies are sitting. But to me, is that too late? So there are we were approached to do a pre-symptomatic trial in SMA, and I think that's where the key is going to be, to treat it before the horse is bolted. But I've talked to newborn screening and it's not on the newborn screen, so really the barrier is, how are we going to prove a drug works if we can't treat it early enough? And we've got to resolve that. But I suppose to wind up and take you back to paediatrics, which is where I see the most devastating nature of SMA, to remind you that it is the most common lethal genetic killer of infants. And I think this is one of our recent patients, and it really presents the challenges. So this is him when he's 7 days old, and what you can see, he looks like a normal baby. He's kicking his legs, he's got good facial expression, he's wriggling his arms, he's moving, I think, completely normal. I would never pick there was anything wrong with this boy. This is him 7 weeks later. He's got a frog leg posture, he's wriggling his hips, but he can't move them against gravity. It's at segmental L2, L3, L4. He's trying to hold on to a toy, but he just can't keep a hold of it. That's in 7 weeks, and that's when he was diagnosed. And to me, it's exciting to do clinical trials, but that's when we're treating them. And my concern is that the clinical trials are not going to prove an effect because we're treating them too late. And I suppose that's the challenge in the trial designs, and it's exciting to develop new therapies and they look really promising, but we really still have to define the therapeutic window, and it's likely that we need to treat these patients, even the Kugelberg-Wieslander patients, early, and really develop outcome measures that are sensitive, that are going to really give us the big hope that if a therapy works, that we can actually prove it and it's not a negative trial because it wasn't done in the correct way. And I think that's a challenge in looking at the ethics, the costs, rationale for newborn screening, and is it that we could do a pilot study to show that if you treat these babies pre-symptomatically, you're going to get a better outcome. So I think the take-home messages are, when you're looking at a patient with SMA, the real money is still in the clinical phenotype, taking the history, looking at the pattern of weakness, using your neurophysiology to help you prove that it's involving the motor nerves, and knowing your genetic testing. Now, I'm lucky enough to work with geneticists, but I still think a working knowledge of what gene to order, what's the sensitivity, what if it comes back negative, what do you do, could it still be that, is essential. And I think the next generation sequencing will have a role, and that's still evolving, and hopefully in 3 years' time, I'll be telling you a different story about treatments. So I'll finish in the words of Charcot, let us keep looking in spite of everything, let us keep searching. It's the best method of finding, and perhaps thanks to our efforts, the verdict we give such a patient tomorrow will not be the same as what we give this man today. And I'd like to thank my supervisors through my PhD, Matthew Kin and Steve Vucic, and also the help of Cindy Lin and Susanna Park, and Huling Tuyo, who's helping us phenotype the new cohorts at the moment. Thanks.
So thanks, Michelle, for a fantastic overview. We've got time for some quick questions if anyone has any. Oh, Garth, I knew we could rely on you.
I'll be in my bed.
Beautiful talk, Michelle. Lovely clinical description. I just want to say that from my point of view, looking at some of these diseases, particularly in adults, it's so difficult to sort out CMT from distal spinal muscular atrophy, which I much prefer the HMN term because it gets confusing when you call everything spinal muscular atrophy. That particularly that gene, BSCL2, it can produce CMT, sensory neuropathy, spastic paraplegia, and a bunch of so it produces a bunch of overlap syndromes. So it makes it rather hard for us to decide which gene to test when a gene can be so promiscuous. And this is true for many genes. So I've been burnt. I can be wrong because I got the phenotype wrong, or the gene can be wrong because it does multiple phenotypes. So we've moved away. We do exome screening now for about $2,000, and we will include in that exome screening for CMT in inverted commas, we'll do spinal muscular atrophy, we'll do motor neuron diseases, we'll do ataxias, we'll do spastic paraplegias, we'll do the whole lot at once because it may be you, the clinician, didn't get it quite right. We'll then give you a report which you won't like because it'll have half a dozen gene mutations on it that your patient might have. But you then can sit down with the patient and the family and try and work out which is the relevant one. That way you've thrown the net wider and you might pick up these variants that are so very tricky. So I just want to follow that point that I think life has got, it's lovely when you've got a clinician like you who can see the clinical phenotypes, but I think for the rest of us, it's a little bit better to throw the net wider.
That was a party political broadcast from Garth Nicholson, Anzac Institute.
And
Alistair.
in one of the patients that we did do whole exome sequencing, I'm glad we have a geneticist because they were also found to be carriers of cystic fibrosis.
No, look, you've raised some interesting questions about newborn screening and maybe even preconception screening. No, we've certainly had patients with SMA who have wanted to go on and reproduce. We've done carrier screening. We've screened then their partners and found that they also carried the gene and moved to PGD. I don't know whether you would do that routinely, but looking at things like newborn screening now for Pompe disease, they do this in Korea. They found 10 cases at birth. They started treatment at birth. These patients do remarkably well on myozyme, much better than they would if they were diagnosed, even a month or two later. You can make a very strong case for actually doing newborn screening for a whole host of diseases, but as you say, it takes a major ethical leap to do this. Plus, if we do newborn screening, why should we screen the parents beforehand? An even greater ethical leap. What are your thoughts?
I've spent some time thinking recently, and there's been surveys of parents, and I think their preference is for population screening. So what that is when you're planning to have a baby, you're going to see the geneticist and being looked at what conditions you do carry. Now, in New South Wales, you can do that. If you go privately and you pay $700, you can find out if you're a carrier for SMA and make decisions about that. So it's available, but it's not available for everybody. And talking to newborn screening, I think there's many different, angles to go. And I think they need to know the cost effectiveness, and saying it prolongs survival by 4 months may not be enough of an argument. That might actually provide more cost on the healthcare system and prolong suffering, which I struggle with consenting these patients for the study, but we still don't know what the outcome is. And I think I heard today that people feel burnt, so they're screening for Krabbe's disease and a few other neurological conditions in New York, and when they did that study, they got 7 babies who had the mutation. And what happened was that they went and did bone marrow transplant in 5 of them, the other 2 refused and ran the natural history. But having a treatment doesn't mean it's a success story. So 2 patients died in transplant. 1 patient had a bad disabling complication, and the other patient, didn't follow the normal natural history but got microcephaly and can't walk in childhood. So I'm not sure that it's universally a success story, but I think really they're issues to think about.
Thanks, Michelle. Beautiful talk. Enjoyed it. So I just wanted to ask you about this emerging genetic therapy. So in that trial where you know, you increase the lifespan for 4 months, did they measure the SMN protein, one protein,
Yep.
and did it increase? And are protein levels a way to determine prognosis in these patients?
So the question is, where do you measure the SMN protein? And if you do it from the blood, it does not correlate with outcome. It has some relevance in the CSF, but again, if you've got burnt out disease, what does that mean? But certainly that was one of the secondary endpoints, and the drug does increase it. But the question is, are you measuring it from the right place? And I guess one of the other things to be resolved is giving it to the CSF enough, or do you need to give it systemically as well? So that's been addressed in animal models, and there's been varying results, and some of them have suggested that you do better with both CSF and systemic delivery. But I think some of the issues with the systemic delivery are the side effects, and it does cause squamous cell hyperplasia, which is not a problem if you give it in the CSF, but some of the animals lost ears and lost tails, so may not be as safe. I think the animal models also revealed the therapeutic window, so that if you gave it before 17 days in a mouse, you got really impressive survival, up to 120 days, whereas normal would be 30 days. Whereas if you started the treatment after 17 days, the effect was minimal. So I think that's why I'm saying we need to treat these people pre-symptomatically based on that.
Just on the neurophysiology, it would be hard to differentiate motor neuropathy from motor neuron degeneration, such as SMA. So when you say that they have motor neuropathy, you mean that they have motor neuronopathy, presumably?
Yes.
Because, I mean, to differentiate it from motor neuropathy per se, electrically would be impossible. Just lose their compound muscle action potential amplitudes, and they're denervated.
Agreed.
They look exactly the same.
Agreed. And in fact, in children, if I'm convinced that that's what it is, I don't do nerve conduction studies. I usually do the genetic test first, and it's only if I get a surprise that I go on and go back and do the neurophysiology then. And I agree with Garth, it's not as simple in adults as it is.
Maybe last question, Raymond.
I'd like to speak about, that was a great talk, thank you. I'd just like to pose to you a question that my children posed to me, which I couldn't answer. What condition do you think Stephen Hawking has?
Matthew?
I always thought he had SMA, but actually watching the movie, they show him getting ready for his lumbar puncture, and he's got clonus and spasticity, so he's clearly got upper motor neuron involvement. And I think also now he's actually going off cognitively. Like anyone who happened to see the presentation at the Opera House recently would understand. He's still obviously brilliant, but and he obviously has a bit of frontal dysfunction in that he's managed to get through a few relationships already, despite being completely paralysed. So I suspect he's got a form of ALS, and maybe that's a message that it is quite an unusual spectrum. I don't know if Michelle wants to say anything further. I think maybe what we'll do is we'll let Michelle off at this stage, but I think it's another thing to remember when any of your colleagues can't get off the dance floor. I think we've got another answer here, so thanks, Michelle.